Hello, my name is Michael Wallace. I'm the John C. Anderson Professor of Medicine at the Mayo Clinic in Jacksonville, Florida. And I'm going to present today our recent article in Gastrointestinal Endoscopy titled The Best of Artificial Intelligence in Gastrointestinal Endoscopy 2024. This was part of a series of articles initiated by the editor-in-chief, Dr. Douglas Adler, to review some of the top material that has been published not just in the Journal of Gastrointestinal Endoscopy, but broadly in the space of gastrointestinal endoscopy throughout the world. In the article, we focused on 10 articles that were of very high importance in the space of AI applications in endoscopy. For the purpose of this talk today, I'm just going to focus on 5 of those, given the time constraints that we have. So let's begin with colonoscopy. Colonoscopy has been the first major application of artificial intelligence in endoscopy, at least the first clinically approved application. We've seen many studies now over the last 3 to 4 years demonstrating the benefit of so-called computer-aided detection, or CAD-E, for polyp or adenoma detection. One of the questions that has come up, however, is how does this impact trainees or novice endoscopists who are just learning? In this particular study, in this multi-center randomized controlled trial from Yao et al., performed in China, they randomized 685 patients to colonoscopy performed by a novice endoscopist with or without artificial intelligence, or a control group of experts performing colonoscopy without artificial intelligence. The hypothesis was that AI would bring the level of the novice up to the expert. All patients underwent a second colonoscopy performed by the expert immediately following the first. And when compared to the expert endoscopist, novice experts were statistically non-inferior meaning their adenoma detection rate was not statistically less than experts when using AI, but they were, as expected, significantly inferior without AI. This was measured by the adenoma detection rate. This very novel study demonstrates that AI has the capacity to elevate the skill set of novice endoscopists to that approaching experts. It remains to be seen, however, how regular use of AI by trainees will impact their ability to perform endoscopy without AI. For example, if a fellow is only learning on AI, do they develop the same skill sets as current physicians who trained in the era prior to AI? This remains to be seen. In our next study, similarly in the field of computer-aided detection, this study, called Artificial Intelligence Assisted Real-Time Monitoring of Effective Withdrawal Time during Colonoscopy, a novel quality marker. While detection and classification of polyps has been a major focus of AI, the current standard quality control measures, including withdrawal time and bowel preparation, are a new area of interest. Although relatively mundane, these require a large amount of work to measure these important tasks. And so if these tasks can be replaced by an AI system to automatically measure quality, withdrawal time, bowel preparation, this would significantly improve endoscopy workflow and efficiency. In this study, they trained the system to calculate the effective withdrawal time by first training it to detect the cecum and the retroflex view of the rectum, and then subtracting the time spent on maneuvers such as biopsy and polypectomy. They also subtracted a time spent where there was a blurred image or obscured image, creating what they called the effective withdrawal time. They then applied this effective withdrawal time and correlated it with adenoma detection rate, much like the very early work that associated withdrawal time to adenoma, or actually polyp detection rate. As with previous studies, they showed a strong correlation between withdrawal time and adenoma detection, but further showed that the AI-derived effective withdrawal time had overall higher accuracy as measured by the ROC characteristic curve, the receiver operating characteristic curve, than the standard withdrawal time calculation. The study was important for several reasons. One, it identified a more accurate way of measuring withdrawal time and strongly correlates that with clinical outcome. The potential for this is quite important, not just for withdrawal time, but bowel preparation, speed of withdrawal, uh, areas that are not well visualized. And these can be given in real-time feedback to the endoscopist, perhaps to look behind a fold that wasn't seen or to clean a particular area that was not clean enough. Let's go on to the third study. Let's focus now on Barrett's esophagus. Two studies from the well-recognized Amsterdam group that's been so instrumental in advancing our knowledge of Barrett's esophagus. We know in Western populations that Barrett's esophagus and the ability to detect and classify dysplasia is especially important. AI has been extensively studied in this topic. In this paper from Kiki Falkens from the highly experienced Amsterdam group, they evaluated a previously developed algorithm for Barrett's using still images and now applied it to real-time video endoscopy. In this pilot study, only 15 patients using the CAD-E system, it detected all visible lesions and thus had a sensitivity of 100%. Specificity was lower, however, with 53% specificity on a per patient basis and a 73% specificity when evaluating for each 2 centimeter segment. This study is important because it is one of the first to translate a previous ex vivo study of still images to live video endoscopic procedures, which is critical for their performance. The study is quite favorable in that it had a remarkably high level of sensitivity. The modest specificity, although concerning, is less critical, is less clinically relevant, as flag lesions will always be further evaluated by the endoscopist, who will make a final human intelligence decision as to whether the lesion requires targeted biopsy or resection, much like we get false positives with colon polyps, and we quickly learn to recognize that these are false alerts. Let's now go to the second Barrett study. Again, this is a multi-center consortium study. The senior author here, Dr. Bergman from the Amsterdam group, again, very well known in the Barrett's endoscopy community. In this second study from Yukuma et al. From Amsterdam, they evaluated the accuracy of a computer-aided diagnosis, CAD-X system, for characterizing Barrett's neoplasia among general gastroenterologists in comparison to a group of 10 internationally recognized Barrett's experts. So similar to the previous theme of can we elevate or democratize expertise? The system was extensively trained on a large library of endoscopic images called GastroNet, consisting of more than 5 million images. It was further retrained on almost 2,000 endoscopic images of Barrett's esophagus in both white light and narrowband imaging. This image set was evaluated by 44 general endoscopists and 10 Barrett's experts. The CAD-E system alone, without any human interpretation, had a near perfect sensitivity of 100% and a specificity of 98% on still images, and 93 and 96% respectively on videos. AI alone, without human interpretation, outperformed the general endoscopist interpretation without CAD-E assistance. However, the accuracy of the general endoscopist significantly increased with CAD-E assistance, increasing their sensitivity to 84 to 96% and their specificity from 90 to 98%, which was equivalent to experts. This study is particularly important in that it demonstrates, like with the colonoscopy paper cited earlier, that CAD-E and CAD-X can elevate the level of the general endoscopist expertise to that equivalent to experts. This emerging theme is that AI systems can democratize expertise in a way that allows it to be deployed at large scale. The system also demonstrates the value of large image repository, GastroNet, developed by the Dutch GI Consortium, to train AI systems for endoscopic image classification. Let's move on now to the field of endoscopic ultrasound. There are many potential EUS applications. I chose this one that is relevant to subepithelial lesions. Subepithelial lesions are common indications for endoscopic ultrasound and include a wide variety of lesions, such as GI stromal tumors, leiomyoma, neuroendocrine tumors, cyst, and anatomical artifacts, such as extrinsic compression from other normal structures. These lesions are typically classified based on their location and echogenicity, but the overall accuracy is modest and often requires performing fine needle biopsy to determine which lesions should be resected. Gastrointestinal stromal tumors and leiomyomas are among the most common of these and are typically resected when they're larger, symptomatic, or have other high risk features, although the ability to predict high grade lesions is limited. In this study from China, from a group that performs a very large number of stromal tumor resections, they trained an AI algorithm on small gastric subepithelial lesions less than 2 centimeters. The data set was particularly valuable since all lesions were eventually resected and thus had definitive histological diagnoses. After training an AI algorithm, they measured the area under the ROC curve, where 0.5 is considered random and 1.0 is considered perfect. The area under the ROC curve for a diagnosis of GIST was 0.76, and for risk stratification into high or low risk was 0.73. Notably, this outperformed or was equivalent to 5 expert endoscopists who had a range between 0.5 and 0.64 for the diagnosis and 0.56 to 0.75 for risk stratification. This study is important because it addresses a clear unmet need in our ability to classify subepithelial lesions and determine which ones require resection. Currently, fine needle biopsy is the most accurate method, but is more expensive and may cause fibrosis from the biopsy itself, which may hinder subsequent submucosal tunnel endoscopic resection, which is the preferred third space procedure for removal of such lesions. To summarize these 5 of the overall 10 articles, AI and computer vision technologies are very rapidly advancing their ability to detect and classify endoscopic lesions. AI is typically performing at or above level of experts and often above the level of novice or trainees or non-expert endoscopists. The initial integration of CAD-E or CAD-X systems for polyps will soon expand to other indications such as quality metrics and other diagnoses in the upper and lower GI tract. Thank you very much.